Capitol Report is a production of Senate Media Services.
Governor Walz urged lawmakers to find agreement on the differing plans offered by the Senate GOP and the House DFL to make life-saving insulin more accessible for Minnesotans. Senator Eric Pratt and Representative Michael Howard outlined the proposals. Stay tuned for this week's Capitol Report. Welcome to this week's program. I'm Shannon Loehrke. Bipartisan agreement on the need to find a way to help insulin-dependent Minnesotans afford the drug faltered at the end of the 2019 legislative session. This week, Governor Walz called a press conference to pressure lawmakers to immediately reach agreement on a plan that will help Minnesotans struggling to afford the life-saving medicine.
I refuse to allow Minnesotans to forget about their neighbors who are dealing with a crisis in access to insulin. Those who may feel like they can run the clock out, or those that may seem to think that people forget about this, are sadly mistaken. This crisis is still upon us. We still have, and you're going to hear stories of young people, instead of looking to the future, are dreading when they turn 26 and fall off their parents' insurance, and the implications that that makes. It's now been 568 days since the first Alec Smith Emergency Insulin Act was introduced back in 2018 by House DFL caucus. It's now been 150 days since the 2019 legislative session ended. 28 days since the Senate Republican caucus released their plan. 21 days since the House DFL caucus released their updated plan. And 16 days since I called them to come together and conference this.
Life in your 20s is, I'm going to be honest, unstable. I'm living paycheck to paycheck. I'm still figuring out who I want to be as a person. And I'm really just figuring out what I want to do with my life. Even on my parents' insurance, I have been guilty of rationing my own insulin. I've had to choose between basic needs like putting gas in my car to get to the job that I need to afford my insulin, or just buying insulin in general.
Earlier this year, a family posted in a diabetes Facebook group reaching out in need of insulin because her husband had run out the night before. She was located in my hometown where my parents live, so I reached out. She explained to me while they couldn't afford their insulin, they also couldn't get the pharmacy to refill their prescription. I told my parents, and they were able to get them what they needed, but afterwards, I got a reaction from my mother I haven't seen since I was diagnosed. We talked on the phone, and she started crying, which made me cry, and it never stopped. But you want to know why she cried? She cried because her daughter is fighting the same battle that those people are. Her daughter is going to turn 26 one day and be on her own. Her daughter might have to resort to a Facebook page just to stay alive. Her daughter's life is in the hands of the greedy. But what she didn't know is that her daughter was going to be fighting the fight for affordable insulin and access to emergency insulin to prevent rationing and deaths from DKA. Diabetes does not care what party you affiliate with, how old you are, or what you do for a living. How many more days are we going to let pass until something gets done? How many more deaths is it going to take until we get access to emergency insulin? I don't know about you guys, but it feels like we're running out of time, and the diabetics who are rationing their insulin don't have any left.
The problem is still upon us. The solution sets in front of us. This is an issue of political will at this point in time. I'm calling upon the legislators to come together, conference their pieces of legislation. Since I've been doing feels like every week since May, the willingness to call a special session, I've said I will do so, focusing on this and giving the certainty to Minnesotans around access to insulin and life-saving care.
As Governor Walz mentioned, the Senate developed an insulin assistance plan. A key Senate committee met in September to review it.
The plan is relatively simple in its concept. First and foremost, this plan provides resources for Minnesotans to get affordable insulin. We achieved this by establishing an insulin affordability program as a safety net for anyone below 400% of the poverty line. This equates to nearly $50,000 for an individual and over $100,000 for a family of four.
Minnesotans with diabetes are frightened and scared that this is an issue and that people are dying. I have an 8-year-old daughter with type 1 diabetes, and while we can afford her insulin, I'm really concerned about her future as a person with diabetes in Minnesota, especially as I see the trajectory of insulin prices over the past 20 years and in the future.
I want to state that I'm grateful that the Senate Republicans have made this issue a priority for your caucus. I'll be honest, we didn't always feel last session that you were listening to us, and consequently, some of you were victims of the ferocity that us mama bears unleash when we feel someone isn't doing enough to protect our kids. While all moms and parents are protective of their children, we diabetes moms are in a special class. Because of the grueling 24/7 nature of managing the disease, we regularly are up in the middle of the night checking our kids' blood sugars and Twitter. So what you should know is that while we'll show our claws if you don't think we're with us, if we don't think that you're with us, we're also quick to embrace with bear hugs those who join us in this fight.
We as advocates have some serious concerns with it. Number one, it doesn't include an emergency program. Diabetics often ration their own appointments because due to cost, due to availability of those schedules of work and transportation. Rural Minnesota has a lack of care providers. Endocrinologists are scarce. General practitioners are not always comfortable with insulin. The time frame seems too long. Lives can be lost during that waiting period. As you could tell from my testimony, my son died in a matter of 24 hours without insulin. I'm concerned doctors already have full plates, and how can we realistically expect them to take on more? We need pharmacies to be in place for this program. Their locations and schedules seem to work better. I think it's a really good idea to encourage people to sign up for MNsure, but as we know, those policies can be extremely expensive. And I'm afraid that there has not been much conversation with the diabetic community. If you want to write a bill that can affect nearly 500,000 people, they should be contributing.
I agree with you that the problem is, I'll call it rip-off pricing. When Mr. Robleski says you can get it for 1/10 as much in Canada, and I think he also is the one who said, and they're not selling it at a loss in Canada, they're selling it at a profit in Canada. And for drugs that are 15, 20 years old, some of them off patent, the fact that they're charging this much, that's the problem. But it strikes me as your bill saying, well, we're not going to deal with the emergency here. That's why we ought to get to the Wicklund bill and deal with that. But my concern is, if we're going to address the pricing, what you've got here is basically a system which would take a lot of people up to 400% of poverty, which is wonderful. I like that. But say that they're going to get a year of, they may well be qualified if they're under 400% of poverty, and they go through this process that they get a year of free insulin, which is good because the pharmaceutical industry, which I would argue has been way overcharging, at least they're giving something back. But the way you're doing it, it strikes me you're making every physician who comes into this situation to be, they're the pharmaceutical manager.
If we can take a significant portion, I don't know, 80, 90% of these cases, and if we can resolve them before that patient is in crisis, before that patient is down to their last few doses and has to decide whether or not to ration, wouldn't you agree that's a better option? And this is not a permanent solution, Senator Marty, because this isn't addressing the issue of drug prices. This is a stopgap measure to help people who are struggling to afford insulin get the life-saving drug that they need.
If one more person in Minnesota dies because the system was unable to come to an agreement on helping that person, we have failed. And there'll be plenty of blame to go around. I'm not going to point my finger at you. I'm going to just, that's what drives me on this thing.
People with complex medical illnesses need more than just the drug. And so by nudging people to their primary care physician shows a concern about the wholeness of their care. And the goal here was to take some of the politics out of this issue and really address it in a way that is proactive, and yet compassionate.
Senator Pratt now joins me in the studio. Thanks for being here.
Thank you.
Insulin for some Minnesotans has become unaffordable, causing some individuals to ration their supply, which can be fatal, as happened to Alec Smith, who is named in the House proposal. You have proposed an insulin patient assistance program. How would it work?
So it's very simple. A patient would go out to MNsure. They would put in their information. MNsure would generate a patient program and a form that they would take to their doctor. The doctor would fill in their prescription information. They'd send it to the manufacturer. This entire process, we believe, can be done in 10 days, and somebody would be able to get help affording their insulin. We do know with Alec that he was having a problem affording his insulin. He was uninsured. This program would cover uninsured, but we're also looking at covering people with private plans and extremely high deductibles, and so we're working through some of those details right now.
And just to be clear then, this program kicks in for people at 400% of poverty, $50,000 a year for one person, or $100,000 for family four, is that correct?
That's about the numbers. It's a little over $100,000 for a family of four. So if you had one person or two people on on insulin, then in your household, the amount for federal poverty level goes up. We thought those were pretty good positions. When I spoke with Alec's mom, certainly he would have qualified under this proposal.
Okay. Lawmakers have been grappling with this issue since last session, as you well know, and one of the sticking points has been who will pay for the free insulin. Your plan requires that manufacturers provide it free of charge to those who qualify. Are the manufacturers on board with this?
The manufacturers do have some concerns. They're concerned that we are expanding the eligibility maybe a little bit beyond their comfort level, but the fact of the matter is they would rather supply the insulin at a wholesale level rather than buying their drugs back at a retail level and subsidizing really what's become an inefficient distribution system with the pharmacy benefit managers and the pharmacies being involved. So what we're trying to do is cut the cost of the program by going direct from manufacturer to consumer through the doctor.
Okay, and then that brings up one of the concerns that was raised in the committee hearing on this, because there's a concern about whether doctors are really able to manage this, because the doctor would be working with the manufacturer to give the insulin to the patient, as opposed to going through the pharmacy, which is set up to do this. There's also a concern possibly about appointment times for people, because there can be long waits to get in to see doctors who do this type of prescribing. What are your thoughts on those two concerns?
Well, and I've talked to the doctors' organization, and I'll continue to have conversations with them. We're still not in agreement, but the fact of the matter is many doctors already have refrigeration available to them. They need it for their vaccines. What we're talking about is just some sort of little refrigerator to keep this insulin cool. As far as an appointment, these should already be existing prescriptions. It shouldn't take much more than a nurse filling in or a receptionist filling in the prescription information and having a doctor sign off on it. We're not asking for a lot. If we get the pharmacists involved, and by the way, the patient assistance programs that all the manufacturers use go through this very channel. So the doctors who already have patients on their assistance programs are already participating in this.
So you're trying to rely on an infrastructure that already does exist.
You talked about who will pay for it. You know, I had a couple of problems with the House bill when it came out. One was who would pay for it, but also the House bill would rely on a pharmacy benefit manager that would take us 9 to 12 months to get up and running, and then required a whole new infrastructure and a whole new department to be built. We're trying to cut cost and shorten the implementation time by using the existing delivery channel.
So the other criticism that has been raised is that this doesn't have that emergency aspect to it. So if someone is just really at the end of their supply of insulin, there's no way for them to just jump in and get it. And advocates for either of these programs are hoping that whatever compromise can be found can have sort of the long-term benefit that you're laying out, but also an emergency aspect. Can both of those things be done?
They can. When I sat through the hearings at the House and even heard this during the session, we talked about insulin affordability. And the fact of the matter is the House plan provides a 90-day supply of insulin, but it has absolutely no answer for what a patient does at day 91. Insulin doesn't get any more affordable after the emergency program. Our goal is to get patients into their doctors and into a program before they hit crisis, before they need to get onto an emergency plan. Now, there's still going to, as I've talked to advocates, there's still going to be some that we need to do that for, and I think we can build an emergency provision in it. But our emergency provision should be much, much smaller than what the House proposal is.
There's still the underlying issue, however, of the skyrocketing price of insulin. What can be done about that?
Well, Senator Benson, I know, is working on some ideas, one including re-importation, so being able to re-import medicine from Canada back to the United States. I mentioned kind of a broken delivery system where the rebates that are being paid on insulin, rebates to pharmacy benefit managers and insurance companies, even the state of Minnesota. The state of Minnesota in 2017 made a profit on insulin because they got more in rebates from drug manufacturers than they paid out in reimbursements. That's what we're trying to avoid. We're trying to avoid that inefficient, expensive delivery system and go from manufacturer to patient.
Underlying this, is it that murkiness that exists about what the true cost of anything in our medical system is?
It really does, and Senator Draheim and Senator Jensen have both proposed transparency bills along that line. And I know in the Senate we passed some transparency. We also mandated that insurers couldn't profit from insulin. And I think that's why you're seeing every MNsure provider now cap their insulin copay at $25. So that is also where we started in July when the bipartisan working group broke up to where we are today. Even my proposal changed over time as the landscape, as the insurance providers stepped up and started providing insulin at a reasonable copay.
Now, you mentioned this. Senator Benson did have an amendment that was put on the HHS bill, and it prevents insurers from Minnesota from profiting off of the cost or the price of insulin. That will take effect in 2020. You mentioned how there are caps now among insurance plans at $25. So that will likely have an effect on the cost of insulin in the state. Do you think that's true?
It absolutely will. I mean, it makes insulin more affordable, and that's what we've been trying to do.
And for those people that don't have insurance but don't qualify, are they still stuck paying those very high prices for insulin?
If they're uninsured and they make over 400% of poverty level, so a family of four making over $100,000, there's a very good chance that they will end up. Now, they could also be qualified for some of the existing patient assistance programs, and I've talked to pharmacists who are ready to hand out information on those programs. Unfortunately, when you draw a line, whether it's at 400% or 600%, somebody's going to be left out. We're trying to cap at 400% of income. We figure we'll capture about 50% of Minnesotans that would qualify.
Senator Pratt, we have to stop, but I want to thank you so much for your time.
Thank you very much.
Lawmakers agree on the urgency of dealing with the high cost of insulin. In September, Senate Republicans unveiled their Insulin Patient Assistance Program, and the House Democrats held a hearing on the Alec Smith Emergency Insulin Act. Joining me to outline the framework of the House proposal is Representative Michael Howard. Thanks for being here.
Thanks for having me.
The Alec Smith Emergency Insulin Act was named for Alec Smith, a 26-year-old man who died in 2017 while rationing his insulin until his next paycheck. There was a bill last session. It did not make it through. What is the gist of the plan right now?
Well, this bill was, as you mentioned, named after Alec Smith and started forming right around the kitchen table of Nicole Smith Holt and James Holt, Alec's parents. And Alec's story, to ration your insulin because you can't afford a life-necessary drug and to pass away, that should just never happen in our state and our country. And we set out to build a plan that provides a safety net so that Minnesotans who might find themselves in that situation have access to insulin when they need it. As you mentioned, this bill cleared the House, a version of it cleared the Senate, but it ultimately the Senate decided they did not want to take this up in the regular session. And since then, we've seen Minnesotans who are outraged. They don't understand how we could not take action on this bill, and that public outcry has pushed us towards action. And we've made improvements to the bill, and I think that because of those voices of Minnesotans, we're moving closer to getting this done.
So the bill or the plan would provide a 90-day emergency supply to someone in that situation that Alec was in. So he could have gone to a pharmacy and gotten a 30-day supply, and then you qualify, and it goes from there. The Senate plan has been called an urgency plan, the House an emergency plan. But Senator Pratt pointed out that this plan does not address the need on day 91. So it helps someone like Alec make it through. But what happens on day 91?
You laid that out really well. You know, first we think we need to address the emergency. That's why our bill makes sure that if a Minnesotan goes into their pharmacist, that moment they can get access to an emergency supply of insulin. That has to be the first step so that we prevent the loss of life. We also need to address the long-term costs, and the Alec Smith Emergency Insulin Act does include direction to connect folks to long-term resources that might be available through the county and otherwise. That's important. Senator Pratt's bill takes another approach to provide a more medium-term, longer-term solution, and there's no reason why those two ideas can't work together. Let's first address the emergency, then address the urgency to make sure that Minnesotans have access to affordable insulin on a continuum of time.
Does it really need to be one and then the other, or is there room for a compromise, do you think? I mean, Governor Walz has said he will call a special session if that can be worked out. In your view, is that likely? Well, to your first question, absolutely. These two ideas are not mutually exclusive. There's no reason why we shouldn't be able to sit down, Democrats, Republicans who've been working on this issue, and agree, let's solve the emergency issue so that no other Minnesotan loses their life because they can't afford their insulin. And let's also make sure that we're providing long-term solutions to their care so that they can get dependable, affordable coverage for their insulin. Right now, the governor and the speaker have said, let's do this. Let's get to the table. Let's work together. And that's my approach, too. I want to get to the table as fast as we can because this is an urgent issue. And we've seen some signs from the Senate, and I hope that we can urgently work together to get this done this fall. Now, both plans set up a fund. Well, actually, no, they don't set up a fund. The House plan will set up a fund that drug makers will pay a licensing fee, so that would provide the insulin. The Senate plan requires drug makers to give the insulin free of charge to those who qualify. Both plans are asking the pharmaceutical companies to be responsible for the costs in one way or another. Why is that?
First, that is a significant move towards reaching consensus. At the end of the legislative session, that was a key hang-up, I believe, for the Senate, that they were unwilling to ask the big pharmaceutical companies to have a large stake in paying for this. And now they've moved towards the House position. That's a good thing because we believe these large, and it's just three, these big three insulin manufacturers that control the global market, they have profited billions and billions of dollars while raising the list price of insulin by 12,000%. An insulin bottle that cost about $30 in 1990 now costs $300. They're responsible for price gouging Minnesotans, and they've profited richly off of it. So they absolutely have a role in solving this. The mechanism that we use to do so, I think we can talk about that and try to find some consensus, but those drug manufacturers, they should be held accountable.
Some insurance plans have now said that they will cap insulin costs at $25 per month. Beginning in January, it will be illegal in Minnesota for an insurance company to make any profit from the price of insulin. So because awareness has grown on this issue, pressure on insurance companies and drug makers is increasing on its own. Are things moving in the right direction?
I think pressure is the key word. Minnesotans are seeing what's happening, Americans are seeing what's happening to the price of insulin, and they're outraged, as they should be. And that public pressure brought by diabetic Minnesotans and Americans that are raising their voice is pushing folks to action. We're seeing insurance companies step up, legislators are stepping up. I will say the drug manufacturers, that's a group that has not stepped up. They need to be part of this solution. They're a huge part of the problem, and that's why it's so vital that they be held accountable.
Critics argue that this program is setting up an entirely new bureaucracy, and it will rely too heavily on the Department of Human Services, which has been plagued by problems of late. Is DHS, which is part of the House plan, the best agency to handle the program?
So a few things there. One, as we've set up this bill and this program, we wanted to use the existing pharmacy network, the existing infrastructure, really go out of our way not to set up a whole new bureaucracy or program, because we want to create as barrier-free a program as possible for patients. And that's what we've done. A Minnesotan can go to the pharmacist that they go to anytime to fill their prescription of insulin. Two, as to DHS, there's actually very little that we're asking directly of DHS to operate this program. The biggest piece, DHS will contract with the pharmacy benefit manager, who has existing contracts with the network of pharmacies. That's the entity that will be the main administrative function. So it's a relatively low ask for DHS. We're not asking them to build a website or anything like that. So we believe this is an efficient use of public resources, and most importantly, creating an effective program that works for patients.
Now, you mentioned that it is going to rely in part on the pharmacy benefit managers, who have also been pointed to as part of the problem with the skyrocketing costs. Does that concern you?
Well, we've taken care in the drafting of the legislation to make sure that pharmacy benefit managers will not be able to use rebates, which has been a huge discussion about how the price of drugs generally have increased. In terms of their role in this bill, it's far smaller than what you traditionally would think of pharmacy benefit managers managing a huge chunk of drugs and putting some on a formulary and others not. So it's not quite the same dynamic. We do need to pay attention to our pharmacy benefit managers. They are an important part of the overall discussion on the cost of prescription drugs.
Representative Howard, thank you so much for your time.
Thank you.
Join us again next week as we delve into more topics affecting Minnesotans. I'm Shannon Loehrke, and on behalf of all of us at Senate Media Services, thanks for watching.